Sometimes we like grandma. I could have killed her because I didn't know better. And sometimes then that's the lesson that, you know what, sometimes bad things happen and sometimes I'm the bad thing. And I have to be mature enough to know that, you know what, I am not perfect either. So I have to do better. I always have to learn and grow, and I have to be mature enough in my growth to know I'm never at the top of my game. I always can do better, right?
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now, here's your host, Kevin McFarland.
Hey, everybody, and welcome back to the Art of Emergency Nursing. This is Kevin McFarland. I'm so happy to have you here. Thanks for listening to the podcast. As always, please share this podcast with a friend, share this with a colleague, share this with people you like, share it with people you don't like, share it with people who need to hear it. I have for you today one of my favorite episodes I've recorded so far. My guest today is an educator, as you will obviously tell with this podcast. And he gets deep. You're going to get to know him a lot better after you listen to this podcast. My guest today is an ER nurse, an educator who travels all over the country doing certification reviews, CEN, CPEN, TCRN. And if you haven't had a chance to see him speak, you really owe it to yourself to do so. He's amazing. My guest is none other than Bill Light. You're going to enjoy this episode. Welcome, everybody, to the Art of Emergency Nursing. My guest today is Bill Light. And Bill, tell the audience a little bit about who you are and what you do.
So thanks, Kevin. I am Bill Light. As you said, I am an emergency nurse from the Oregon area. I've been an emergency nurse since 2001. I practiced at the bedside for most of that. A little bit of work on the floor. I did some pediatric and float pool kind of stuff, a little bit here and there. Then came into the emergency department and really never left. Did most of that time at the bedside, a little bit of leadership, charge and educator kind of work. Later in my career, about 20 years, I've done some nursing supervision. Now I'm currently doing education around the country. I'm the chief nursing officer for an education company for Solom Enterprises, but still doing a little bit of PRN work just to try to keep my skills up there. But they're, my full-time work at the bedside is a little bit of my past. So, but that's kind of what I do.
Perfect. What's your favorite part about being an educator?
I think now I love finding that passion, seeing what I was, the things that I was so excited about in my first few years as a nurse. When let's be honest, I was super green when I first started. I had no medical background, no nursing background. I did nothing before. I wasn't, an EMT or a paramedic. I wasn't a CNA. I didn't do that. I was at school, and then boom, I went into nursing. And so I came in very green to a clinical perspective. So I had all this ideas, all this in my head, but I had no like clinical skill. And so I stumbled a lot at first. And so it took me a long time to really marry the two. So I love now as an educator to be able to see these nurses who might be somewhat like me, who come out of a school, be it an ADN or a BSN program, and they're super passionate. I see all this fire in them, and I want to connect those dots for them. All those things that you and I might have taken as a decade to really get these aha moments, and I want to help them with that. I want to fast forward for them. I want to get them to that level of competence that you and I struggled with for a really long time, and I want to see if I can speed that up for them. So I think as an educator, we have this beautiful opportunity to help them see how that classroom sort of education that they got and the real world clinical scenarios, how they really can marry so well. And if you break them down and find the pathophys and marry that with the clinical knowledge and the real um, patient scenario, man, everything just explodes. All these aha moments, and so that's what I love. I love to see that spark in their eyes. So that's what I love about educating. Jeff Solheim, Jeff taught me that probably 10 years ago, and that's one of the things that those little secrets that he told me, why he does it, and it was so true. I was like, oh my gosh, the first time you see that in a class, when you watch their heads just kind of go, poof, you're like, whoa, I want to do that again.
Yeah, they're
That
like,
was awesome.
they're like, oh my God, I never knew that. And you're like,
Yeah,
yes, yes,
yeah,
I'm teaching
and
you. You're learning.
yeah, I know. You're like, yeah. And the first time you get a class to go, oh my God, why weren't you in my nursing school? Why didn't you teach me this in school? I'm like, I know. And you're like, man, if I had a nickel for every time I heard that. But you did, and like your instructors did teach you this. You just weren't at a place at that point to hear it.
Yeah,
And
it
that's what I
wasn't
tell them.
connecting.
Yeah, and like and that's the thing. It's like we all heard this a million times. We weren't at a place until you're doing it. You're just it just goes over your head
It just
because
doesn't matter. You have no
yeah,
context.
it's like you're like a sieve and it just sort of goes right through. Like you heard it, it just you have to hear it in the right context at the right place. And not that I'm doing anything magical and you're probably not doing anything magical. It's just we happen to catch them in the right place. So we got it. We have them in the perfect recipe and we're able to make something out of it. And that's what I love what you and I get to do.
Absolutely. One of the coolest things is after a class, when someone reaches out to you after a class and been like, hey, you taught me about X, Y, and Z, and I seen it the next day. And
Yeah,
you're like,
exactly.
and you're like, oh, I know this. This is amazing.
Yeah. And then I'd love to point out, and then the very next line in that email is, hey, but you know what? You saw it 3 weeks before that too, and a year before it too. You just didn't realize.
Yep.
And then they look back and they're like, you're probably right. Yeah. See, it's not magical, but now you just paid attention. You just realized, but it's there. And then they'll go off and they'll find 3 other people in their staff and they'll teach it and they'll ripple it, and
Absolutely.
that's the beauty. And that's what an expert nurse does. It's infectious. So,
Absolutely.
and that's
Absolutely.
why I love taking the experience that I gained. And I mourned, right? I mourned when I left the bedside full time, right? I felt like a part of me died, because being a bedside nurse, that's what I was. That's what
Yeah.
it was what I
Becomes your identity.
built. It is, right? And then I really mourned it when I wasn't doing it every day. And I still struggle even now. I'm like, I need to do more. I'm losing it. Like right now, I was just telling actually a class recently. I was talking about, you probably don't want me to start your IV anymore. I used to be the best. I was one of those that, you might call me if you needed a hard stick on a kid. Like I was one of those that you might have called, right? But now you don't want me. Even like that young buck who has these gigantic ropes for veins. Yeah, maybe call somebody else. I got it up here. But my hands don't
Hands, yeah, it doesn't necessarily go to the hands. You'd be surprised how fast it comes back. It really is like riding a bike. I mean, I was kind of out of clinical for a little while doing leadership stuff, and then when I got back into the bedside, and especially when I got back into the peds bedside, I'm working PRN in peds, and it came back quick. And I remember the first time, my first day of orientation, I go and I start an IV on, I don't know, like a 10-year-old developmentally delayed kid. IV went well, no big deal, piece of cake. And I mean, I started IVs on adults, daily in my full-time job. And then the very next patient was a 2-week-old, and she goes, "You ready?" I said, "Yeah, let's do this." So I remember, unsheathing that 24 gauge angiocath and then thinking to myself that I haven't played with one of those in probably 10 years. And I remember looking at it going, hopefully this goes well. And she laughed at me because I kind of lifted my glasses up and put them up on my head. And she's like, "You're taking off your glasses to start the IV?" I'm like, "A little better for close range." And sure enough, I got it. And I was like going, "God damn it, that's awesome." And I just remember thinking to myself, holy cow. And I didn't think, I wouldn't have thought that I would have been able to do it. But sure enough, I nailed it. And I remember feeling like, top of the world.
Yeah.
So you'd be surprised how fast it comes back.
Yeah. It's always like, I haven't picked up a shift in a while and I pick up a shift. The first few, I'm like, hey, somebody want to back me up on this.
Yeah, yeah.
Instead of the
Double
two,
check
I'm going
me
to do
here.
one. I'm going to do one. If I don't get it on the first try, I'm going to grab somebody else because I'm not going to be a hero in this room. Because, mm, after the second or third shift, I pick up in short succession. Then it does get better, right? Because I know it up here. I just got to make my hands remember that I know it.
Yeah, and
But
it's hard. It's hard if you're a
yeah,
PRN and you do
but
it
it's hard.
infrequently enough. It feels like every day is your first day.
Yeah, and it's hard on your ego, right? Because
Oh yeah,
your
totally.
brain still thinks you got it,
Your
right?
brain still thinks you're a badass, and your hands are going,
Yeah.
maybe
But
not.
but you gotta be able to set your ego aside enough and go, you know what? There are other people here that are better clinically than me now, right? I am
Absolutely,
not the there are a lot of other people who are better than me. I've got to step out of the way and let somebody else step in. I will guide them, I will answer questions, and that is my role now, right? And that was a really hard part for me, and that's okay. I'm happy with that position because at some point somebody else has got to take the lead. And
Absolutely,
yeah,
absolutely,
so it was a hard one, but it's a good one. And I really like the place that I'm in, and I like being able to to offer that, right? And just to watch other people thrive, man, it is to live vicariously through them. Then to watch them, and in the place I'm in, I focus and we focus with our company. We focus so much on certification, on really increasing, that professional goal and so to hear those daily emails come in about, oh my gosh, you really your class or Jeff's class or any of the other, Andrea's or Kristen's or anybody's class, it really changed everything. I'm really ready. I took my test. I passed. It was really, it was amazing. That really helps
what a
me.
great feeling.
Yeah. So while I'm not the badass in the department anymore, or if I ever was, right? But if I, that feeling isn't necessarily what drives me anymore. It just has to be something different.
Absolutely.
But anyway, you're not here to talk about my woes, right?
So if it was all gone tomorrow, if you lost your nursing license tomorrow, what would you do?
I would turn these skills into something else. I would. There's always more. But the practice license is, the license is to practice. The skills can help with so much more, though. That's what's so beautiful about what we do, is there's so much more than just applying it to a patient, right?
Absolutely,
Um, the knowledge of how it all factors together can do so much, right? Yeah. So
absolutely.
there's still so much to do with it.
That's true. That's true.
Yeah.
Tell me about a patient that changed the way you practice.
Oh goodness, there's been so much. Um, well, there's a few. Let's talk about one. We'll start at a little higher note. Um, One that changed early on. Um, since I don't remember the details, I think this will be safe to say. So there was a little girl. I believe she was. I don't remember the age, so let's make it up. She was around 13 or 14, right? So preteen or young teenage girl, but young, right? Um, Her name was like Lily or something like that. So you can envision like a young girl, right? And she new onset type 2 diabetic, and so I was still it was in the old department, so it had to be in the first 5 years or so of my nursing practice. So I was fairly young, and she taught me something amazing about diabetes. Until then, I just thought diabetes was diabetes, right? It was just they're both high blood sugar kind of things, and they're
Yeah,
both whatever, right? I didn't really get the difference between type 1 and type 2, but and then kids, you think type 1 thing, right? You think it's an insulin problem, and you think type 2 is generally, an acquired thing for later, but Lily was type 2 and new onset, not expecting it. And so her blood sugar, I remember for some reason, I can remember her blood sugar was 1452. I don't
wow.
know why that sticks in my head, but it was 1452. It's very high, right? And so for the longest time, that became the norm for me for type 2 diabetes. It's not, it's very, very high. That's a very high, but it taught me something about blood sugars in diabetic patients because it really, and my preceptor was amazing, Carol Mizak, amazing nurse from here in Oregon, and just she was my original preceptor when I came to the ED, and just one of the best emergency nurses I will ever get the opportunity to work with. But she taught me so much. But she pulled me aside when I was working with Lily, and she wasn't my preceptor anymore, but she's a great friend of mine. But she was helping me with this patient, and she pulled me aside and she reminded me. She said, "Bill, remember that her blood sugar is not the number isn't important because once it gets that high, it's not telling you anything accurate because blood sugars are based on their volume status because they're grams per deciliter, right? They're telling you it's sugar in the volume.
Mm-hmm.
But as soon as they get high, they dehydrate themselves. That's the physiology. So the higher the blood sugar gets, the more dehydrated the patient is, which makes the blood sugar higher, makes it look higher. So the number becomes irrelevant, right? You just know that she's super, 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 super dry. And that's the patient you have. And I was like, oh, so
That's
she
a
needs
good point.
volume, right?
Yeah.
She needs volume. She's like, yes, but she needs volume desperately. So remember, she can't handle volume. She can't handle it fast. So you got to give it really slow, Bill, really slow. And I was like, what? That's counterintuitive. She's like, I know, but you're going to hurt her if you give her boluses. You got to give it slow. And it was the first time I realized, like, a big aha moment for me. Carol was warning me that I could give her injuries, right? I could give her cerebral edemas and things. So it was something that her caution to me really reminded me to dig in. And I didn't necessarily understand it, but she helped me keep from hurting this little girl. And so later I dug into the physiology because that's kind of the nerd I am, right? If something I don't understand it, then I need to figure it out. So I spent a lot of time after that researching the physiology and how it actually works and why. And but it's true, and that's why the blood sugar is an H and a T, if you will. If you want to go back to American Heart's sort of approach to it,
Yeah.
it's a cause of the problem, but it's not the actual thing that's killing her. The dehydration is actually the thing that's hurting her, and it's the organ failure, and it's the resulting lethargy and the decreased perfusion. That's actually what's hurting Lily, not really the blood sugar. The blood sugar is actually just the impetus that made her dehydrated, and that was such an aha moment for me. So that was one of the things that really truly impacted my care on patients with high blood sugar. And then it rippled so much further than just diabetes. Diabetes is just one example of how someone might become hyperglycemic. And it just rippled from there, and then I could just see. And so now even in my courses, I really take that extra time to explain that it's really just a passive process. And once somebody gets hyperglycemic, it it ripples into all of this, and that's why they pee their brains out, why their kidneys, they pull volume from the interstitial space, and it causes them to express more fluid out. That's why they waste their volume, and the whole thing ripples.
All
I
these
could
all these
I
bad
could
things that happen with
Right,
DKA that are
right.
all, not just a sugar problem.
Yeah, it's really almost all of it ultimately is going to ripple down into a dehydration problem. But in kids especially, that osmolar change, right? It has to be addressed. And so if you dump in a crystalloid, usually is what we're going to choose, right? If you dump it in too fast, now adults, you and I might be able to tolerate it because we have a little better ability to sort of modulate that influx of fluid. But these kids, they can't, especially the younger they are. You get that quite young, that school age, even to Lily's age, maybe, right? Um, they're going to lose control of that potentially, and then have tissue edemas, including cerebral edemas, and that could create brain injuries, especially in your small children, right? And that could be irreversible. So that was what I learned, you know. So it was a huge learning curve, and also to not just think of type 2 diabetics as having these huge blood sugars. Just remembering once they get very dehydrated, which is why you think of type 2s as being very, very high blood sugars. It's really that they get more dehydrated than your type 1s. It's because type 1s get ketotic, or really get acidotic, excuse me. And so the acidosis makes them toxic, and so they seek treatment more rapidly. So they just generally get treatment before they get as dehydrated.
It's a good point. I never really thought about that, but that's actually true.
Yeah. And so that's actually the saving grace. That's actually why type 1s in general have a better survival. Their mortality is not as high. It's not that they aren't as sick, or in fact, they might actually be sicker, but they seek treatment better. Another analogy I sometimes throw out to people is think of the two, type 1 and type 2. Think of them like you'd think of anaphylaxis and sepsis, right? Both of them are a similar style of problem in the body. They're both vasodilatory shocks, right?
Yep.
But anaphylaxis, we all see it rapidly and we treat it quickly, right? So generally, anaphylaxis people survive it generally, right? I mean, granted, their airway can close and it could be very bad, right? But you generally don't they don't set for days at home, right?
Where your
But
septic patient very well may.
they might, and then by the time they get in, they're often so far gone that you just sometimes can't fix them, even though you might know how to fix them. They're at the point of organ collapse, right? And system failure. And that's kind of, the analogy doesn't hold perfectly, but it might lend some credence to the understanding of the two.
No, sir. I think that's a great analogy. I think it's a great analogy that I've never really thought of is how, and it makes a difference is how fast are people going to seek treatment. Because, we always see grandma that's been, sick for, weeks and weeks and weeks. And finally they're like, hey, we should probably take grandma. And you're like, yeah, you should have taken her in like a month ago. She's super septic.
And we classically throw like assisted living or nursing homes under the bus. And it's not that. And it's not that they did anything wrong.
Okay, it's sometimes that.
Sometimes. But not necessarily throwing them under the bus. But think of the person who's in that position. It's that they don't necessarily have anyone looking at them daily, right? They have maybe a facility who has guidelines of when they can call, right? So there might be a resistance to bring them in. Does that make sense?
Yeah.
So they have to get approval or whatever, or they have to get a hold of family to get approval to bring them in. I mean, there might be a reason why they can't just immediately go in as soon as someone's concerned. Where if I'm at home and I see grandma and it's my grandma, I'm like, oh God, grandma, I'm gonna take you in. I'm gonna let you see somebody.
Absolutely.
The threshold of resistance there is much lower if it's my grandma at home.
True.
So I mean, it's not really to blame someone who works in an assisted living. That's not what I'm trying to say here. But that is the stereotype, right? So, but either way.
Yeah, absolutely.
Same basic idea.
Yeah, it's
but
great.
It does remind us there that anyone who has a high blood sugar, you have to take it seriously.
Absolutely.
Diabetic or not, that's actually moot. We don't care if they're diabetic. We care that the blood sugar is above the threshold. And in general, I just say, hey, if your blood sugar is over about 160, I should be concerned because that causes physiologic shift. So that's my general rule.
Yeah. No, I think that's, when you look at that high blood sugar, you're like, that's a little concerning.
Mm-hmm.
It should
raise
a red flag, regardless what causes it. You're absolutely right.
Kid, adult, it doesn't matter if it's a stress response, it's causing harm. Like it paralyzes neutrophils, so they're at risk for secondary infection. It's causing shift of their fluid from the interstitial space, causing prevention of lymphatic fluid from transferring, from absorption, tissue perfusion, things like that. I mean, it just does all kinds of physiologic changes. It could be acute or chronic, we don't know, but when we see them as a snapshot in the emergency department, we should investigate it, right? But that would prevent us from sending Lily home, right? And Lily taught me that.
Absolutely.
So anyway, that was long-winded, but
it's good. It's good. Tell me about the first time you made a medication error.
Oh gosh, I made a lot of them. FYI, most of them, thankfully, were benign. I mean, simple things. But I will tell you, there was one big one. I made a big goof, and I share this a lot. So, but I'll share this one. This was a little later in my career, about 6-7 years into my career. I had just changed hospitals. I was in the Portland area at this point, and working at a hospital. So they didn't know me. It's sort of the key to this point. I was relatively new. I mean, I wasn't a brand new nurse, but I was new to this area. And so a woman. I call her grandma because I don't really know anything about her, but she was in her 80s ish. I don't know. I don't remember exactly, but she'd come in by medic, the classic feek and weeble, right? She had, mildly hypotensive. I'm gonna make up numbers because I don't know. Let's say she was like 90 over 60, and she was like mildly tachycardic. Let's say she was like, 110 heart rate, right? So not great, but she wasn't like coding, right? But she wasn't doing great. Something wasn't quite right. So she goes to one of our non-resuscitation rooms, and she wasn't my patient, but as we're all want to do, like 5 of us descended onto that room to help the nurse who got assigned that. And so the doc went to the room, and it doesn't matter who the people were, but people all went in to help. And so I was one of those. And so the doc in the room, in the course of treatment, early on in the course, right? People starting lines and things, and the doc ordered dopamine. Um, and he just looked at me because I happened to be standing near the head of the bed. He said, Bill, um, grab dopamine, get dopamine started. Perfect. I was like, I've heard of dopamine. In my head, I'm like, I've heard of dopamine. I'll do that. That sounds fine,
Yeah.
right?
Yeah.
In my head, I'm like, I know dopamine. It's fine. I've heard of it. It's a pressor, right? I could do that. It seems fine, right? Not realizing that I don't know crap about dopamine, right? Thinking that dopamine's just a receptor site agonist and it'll just squeeze her vessels, right? That's not true, but I'll hold that thought for a second. So I get it. I grab it. I crack the cart. It's on the top shelf of the cart. I just grab it out. I grab a pump, right? I do all the things I'm supposed to do. I prime it. I get it. I put it in. We have weights, bed scales. So somebody punches the bed and gets grandma's weight, and I punch it in. I do all the things right, right? And I turn to the doc and I call him by name and I say, "What do you want to start this at?" And I remember him saying something to the effect of, let's start low. Let's just see how she does. Let's start at 5 and just we'll just titrate it up as we need to. That sounds perfectly fine to me because I remember Carol. I mentioned her before. Carol had told me, hey, little trick when you're not sure where to start something. Almost everything starts at 5. Sounds fine to me, right? That sounds fine. Nothing's not putting off any alarms in my head.
Never
Fine
really,
sounds fine.
never really thought about that, but that's true.
Almost everything does, except dopamine, FYI.
Yeah. 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 Except
Yeah,
for dopamine.
not not dopamine, but almost everything else does. Almost everything else does start at 5. It's kind of true. So it's fine. And even on the pump, those old Braun side pumps, right? It even had a choice, 2 settings for dopamine. It said you can start at 5 mics per kilo per minute or 10 mics per kilo per minute. So I was like, hey, this sounds, it's reaffirming this choice. So it sounds good. So I clicked into 5 mics per kilo per minute, set grandma's weight in there, and started it. And I even double checked the room. I said, everyone agree. Everyone agreed with me. I felt really good about this decision, right? I'm solid here. So I started. Starts um, infusing this, and grandma's blood pressure starts dropping, and her heart rate starts going up, right? Not the way we wanted it to happen, right?
Yeah.
So turn to the doc. The doc's like, well, let's just titrate it up. So we titrated it up to 6 or so. I don't know, right? We bumped it up, right? A little bit further, and it got worse. Her blood pressure continued to drop. Her heart rate continued to go up. Now, at this point, we switched to something else. Because and the answer, the reason was she, quote, didn't tolerate dopamine. Now I can remember hearing that over and over and over, and I can remember my preceptor early on telling me that sometimes people just don't tolerate dopamine. There was big air quotes you couldn't see, but I was doing big air quotes there.
Yeah.
Yeah, and she said that sometimes people just tack out with dopamine. Sometimes people can't tolerate dopamine; they just tack out, and I just accepted that as just an intolerance to dopamine. What I learned that day from grandma was that that is a normal response if you give dopamine wrong. So what I learned that day, now grandma lived, good take home here. Once we switched off of dopamine and gave an appropriate pressor, she lived. And here's what I learned later. Now, just fun facts. Had grandma died and this gone to a review board in the state of Oregon
It's all
and
you.
probably every other state, it would have been my fault because I pushed that drug. Doesn't matter that the doctor ordered it. Doesn't matter that I verified it to the room and everyone in the room agreed with me. I gave the drug wrong. I gave the cardiac dose of dopamine instead of the vascular dose of dopamine. I should have known better. I should have known the drug I was giving, and I didn't. So what I tell this story in my review courses all the time, which is probably not going to be a question on your exams. Probably it could be. I mean, it's a valid question, but probably they don't get that far in the weeds. But I tell people it is a great question for life, right? Because I made this mistake, and I never want anyone, because this haunted me for a long time. When because at my hospital they made a mock review board out of this case, and they called
Oh
me in front
wow.
of the review board, and they did it. They warned me that they were going to call this review board, and they said it is only for your benefit. We're not sending it forward. There was nothing. The family did not call it. Nothing is happening from this, but we do this because we want you to know what could have happened. This is what would have happened, and they called me in front of this review board, this mock review, and it was horrifying. It was mortifying to being called in front of this review board and to have to answer for my mistake. It was terrible. It was horrifying. But had she died, it would have been my fault. And I remember the doctor, and I won't say his name. He's actually a really great friend of mine. But he was like, no, 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 it's my fault. It's my fault. I did it wrong. I did it. I totally told him to do this. And they're like, it's actually legally, it's not. I mean, yes, there's some things that, you shouldn't have done that, but ultimately he's the one who did it. He gave it. And his license says he needs to know the drugs he's given. And that was a huge lesson for me. You know, nurses have to know what they're giving. But just as an aside, to finish, to circle back around on this, just so we know, dopamine is a neurotransmitter, and dopamine is dosed based on the concentration at the receptor sites, not just simply the dose. And so if it's given at less than 5 mics per kilo per minute, it actually affects the kidneys.
Yeah.
That's the renal dose, right? But if it's given I always say between 5 and 10 mics, it's actually not exactly right, but it keeps people safe. Then it's a cardiac dose. So it's a positive inotrope at that point. It's going to increase the squeeze and the rate. And that's what I was giving grandma. She didn't need that. She wasn't cardiogenic shock. She wasn't bradycardic. And that's what I was doing to her. I was just making her work harder. She didn't need that.
Yeah.
But if you want to squeeze, you have to give it greater than 10 mics per kilo per minute. And at that concentration, it'll act as a vasoconstrictor. But I didn't know that. But that's why it's on every code card, because dopamine does everything pretty
A
much.
couple things. Yeah, for sure.
Yeah. Yeah.
And
But even American Heart says that.
Yeah.
Like, they're pretty clear about it.
Absolutely. The dosage you talked about of the, kind of that 5 to 10 being the cutoff. That's kind of how I remember it too.
Yeah. Yeah. And I think if you're being honest, I think if you look at the actual insert, I think it's 2 to 10 is the cardiac dose, but 1 to 4 or 1 to 3, 1 to 4, something like that is the renal dose. So they overlap. And that's why I always just tell people, if you want the cardiac dose, go 5 to 10, because if you go 2 to 5, you're going to get both renal and cardiac. And then that causes you problems, right?
Yeah.
So I just try to draw the line when I teach people. Hey, just make it clear, do single effects.
Let's make a hard cut and focus on what we want to focus on.
Yeah. I mean, so yeah, you can split hairs, but you're going to get multiple effects that you can't control then. So.
That's a great story. Great lesson.
But yeah, it haunted me for a really long time. So I never, ever want anyone out there to go through that. So I'd much rather you just learn from my mistake. Right. And I've made a lot of mistakes, right? Like I told you, I was a dumb nurse when I started. I really was. I mean, I fully admit it. I mean, I made a lot of mistakes. I had a lot of really great nurses around me that helped me and thankfully kept me from killing people. Right. That's great. People helped me. A lot of people really, really helped me. But I didn't know what I didn't know. And I had a lot of help. And so that's why I want to give back, and I want to tell people, I'll be fully honest with people. I made mistakes, right? I've made a lot of mistakes. And if people can learn from those mistakes, then more power to you. Please learn from them, right? So
absolutely.
But grandma was one. She was a big one for me. I will and I fully respect dopamine now. I actually quite like the drug. I think it's probably short-sighted. I mean, I don't think it lasts forever, at least in my uses of it. It tends to sort of bleed a little bit, but great in the short term, I think.
It's a good start.
I think so. So now I don't I work in the ED, so and I don't keep these patients, thankfully, for a huge amount of time, but I don't see it used for days, right?
No.
It's let's get you transitioned to something that I have a little more control over.
Let's get you up to the ICU, and then we'll get you
That's what
something
I
else.
hope. That's what I hope. But
Let's get you up to the ICU, and we'll go from there.
but on that same vein, I mean, there's been a couple other, but on different sides of it. We had another, no mistakes. So I've been talking about mistakes, but sometimes there's not a mistake to be had. We had another in the same ED, right? We had another. If I can tell another story,
Please.
we had a kid who came in, 14-year-old little Russian boy, and he came in from school. He was on the playground, and I don't have any other information, so I don't think this is going to be a violation of anything. But he was. They were playing like maybe football or something, playing with a ball of some sort, and someone kicked the ball, and it hit him in the chest, according to the story. And so all we heard was a ball was kicked, the kid was struck in the chest or throat or something, and he fell. He went down. Witnessed collapse. Immediate CPR was started by BLS trained teachers. They witnessed it. Immediate CPR, and everything was started correctly. The fire station is literally across a chain link fence from the playground. So within minutes, the fire
department's there.
Fire department was there. So like the response was textbook. I mean, could not have been better, right? They jumped the fence. They were there. They did full. I believe when they arrived to us, and they're literally just down the street from us. So response time was transport time was very short. But I think they had 2 lines in him. They had done 2 rounds of PALs with shocks and drugs, but they got to us, no response. So our differentials, when we were thinking, gosh, it could have been anything. It could have been tension. It could have been a pericardial. It could have been a tracheobronchial tear, for all we knew. Could have been aortic injuries. Ended up being a blunt cardiac injury, though.
Yeah.
So that ultimately, and this was just autopsy driven, because nothing else worked, right? So it was super frustrating because this was a kid who had no cardiac history. He had perfectly healthy young boy. And it also sucks that it was just a perfect, beautiful, like everyone's child. Like everyone in that room could relate to this little boy, right? And he comes in, his mother in tow, just beside herself with grief, right? And what do you want to do as a nurse? You want to save this little boy, right?
More than anything.
Right. And ooh, it's making me a little emotional. And you do everything right. And you wish when things aren't going well, you want to blame something.
Yeah.
You want to like, oh, if only somebody had been there, had seen him go down.
Yeah.
They did.
They did.
Well, if only we had better trained teachers. We did. They had perfectly up to date, perfect BLS training. If only fire department had arrived in time. They did. If only they had done all the right things. They did. If only they had, gotten their lines. They did. If only everything was perfect. This little boy still died. It was so frustrating. It was heartbreaking.
It's crushing. It's crushing.
Right. Yeah. And so it was one of the first times in my career that I learned that you can't always win. No matter what you do, no matter how you prepare, sometimes saving that patient isn't what you were there for that day.
Oh, God.
Yeah. And it was a hard lesson, right? But what we found in that moment, the mother, of course, her grief for her child was palpable, right? But one of the things that she kept saying was, and she called him by name, and honestly, I don't remember what it was, but, she kept apologizing. Oh, baby, I'm so sorry. I know you wanted a haircut, and I didn't have time, and I didn't get it. She kept saying that to him, and she kept apologizing that he just wanted a haircut. He'd been asking for a haircut, and she just kept combing his kind of shaggy hair. and she kept apologizing to him and crying. And so one of the nurses, whew, it's gonna make me cry, but one of the nurses called upstairs to L&D and got one of the memory boxes that we would use for the newborns. And they got that and brought it down. And inside it has scissors to take a clipping of hair. And so we got permission from the coroner, and she was able to do a haircut for him. And
Wow.
yeah, ooh, that's gonna make me cry. But so in that moment, the thing we decided that, in our debriefing, the thing that we decided that maybe our 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 ability to affect change that day was to help mom,
Yeah.
give her that little bit of solace.
Your patient changes.
Yeah, yeah.
Yeah.
But it affected you though. But you realize that, and people ask me that all the time, over the years, and I'm sure they have you and everyone else listening. You tell people that you're an emergency nurse, and they're like, "Oh my gosh, that must be so stressful." You know what?
Sometimes.
I think being
Eh,
a CPA is probably the most stressful job I can think of. Dealing with somebody else's money, ugh, that would be terrible. But our job is stressful, but it's not the stress that people think it is. It's not the emergency that's stressful. 'Cause, gosh, good Lord,
That's easy.
that's just Tuesday, right? I mean, that's well, you deal with that. You've seen it before. You know how to deal with that. It's the human emotion that's stressful, that wears on you.
Yeah, that's the
That
hard
stuff,
part.
that stuff. It's stuff you've never dealt with before,
Yeah.
or things that get too close to home. That's the stuff that you carry on forever. The
Absolutely.
amputations, the fractures, the stuff that other people blanch at. We don't bat an eye at it.
Yeah, you're like,
We
whatever, that's fine.
we go grab our lunch after that, right? It's no big deal, right? It's just different. It's just different. But that was one of the maybe not the first one, but that was certainly one that stands out in my head. To just um, not necessarily my mortality, but my humanity, my limits as a nurse. Um, as an ED nurse, I think of myself as unstoppable,
Yeah,
right?
it's easy. It's easy to think, you get enough experience under your belt, and you think you're pretty awesome, and you're like, oh, I
Yeah,
got this. This is easy. Holy
I'm
cow.
10 foot bulletproof. I can take care of anything. You
Yeah,
bring it to me, I can solve it,
you're like,
right? Or at least I can
got
get it to
this.
ICU.
Got this.
Yeah,
I'm your guy. I got this. And you're like, next thing you know, you're sobbing in the corner.
right, right. In the fetal position. Yeah.
Absolutely, absolutely.
So yeah, that little Russian boy, I have no idea what his name is, but you know,
You'll
he
never
changed
forget him.
me. Yeah, he changed me.
Wow.
But he changed us all because we all did everything right, and he still left us. You know. But and if I can do one more, um,
Please.
on the same vein, something that another downer, it's going to be a Debbie Downer here, but another one that really taught me the the necessity of self-care, um, was a little baby named Isabella. I don't know anything else about her, but I remember her name. Um, she was it was actually okay. So let me set the stage a little bit. It was early on in my career, and I was working day shift, and we came on, and I'm one of those neurotic people. I always show up 20 minutes early. My mom taught me that as a kid. She's like, if you're on time for anything, you're late, right?
Yep.
You need to be at least 15 minutes early for anything. Um, never make people wait for you. That's just the ultimate of rude, right? So for shifts, I'm usually, that guy who's there in the break room 20 minutes early. And so it just, it's not that I'm awesome. It's just that's my mother would beat me if I wasn't, right? And so I was, me and several others were there in the break room early, and it was a terrible night. Night shift was just getting their asses handed to them that night, which is not uncommon, right? But for any shift, but that night was especially bad, I remember. And the charge from day shift. She, of course, was there early, getting a report. And so she comes into the break room and grabs the 3 or 4 of us that were there early. And she says, "Hey guys, night shift's just getting killed out there. Can you guys clock in early and just go get started and help them? It would really, really mean a lot to them." And we're like, "Absolutely. That team out there would do anything for us. They would do exactly the same thing. They're amazing. And yeah, we'll do it. Absolutely. We'll clock right in." So we all clocked in and ran out. And so she assigned us to different things. So she assigned me to, she was like, "Hey, room 3 is going to get, they have a code 3 medic on their way. It's a 6-day-old coming in. Can you go take that? Just take that for whoever has room 3. Let them get on to something else." "Absolutely, I'll take that." So I went into room 3 and I'm getting ready for this 6-day-old. So I go in and it's a 6-day-old, suspected abuse, arrest. Yeah. So I'm like, whoa. And I am new. Like I'm not awesome, right? I have all my core training, right? I've probably been a nurse for 3 or 4 years, right? But
Yeah.
I'm not the peds expert yet, right? So, but I'm gonna do it. I'm gonna hold it together, and it's just me to start, right? So I get some more teammates shortly, but to me, it's just me at first, and then after 15-20 minutes, I get some more team members. It's me, RT, and a tech. But so we work this baby for about 3 hours. Um, Off and on, get little flutters of you know things back. It never looks good, right? Um, and she dies. She ultimately, we don't get her back. It's an unsuccessful resuscitation. But we work and we work and we work. And in my heart of hearts, I just know that son of a bitch in the corner did it to her, right? And that's all that goes through my mind the
Oh my
whole
God, that's
time.
so hard.
But
Oh,
I'm trying my best to stay focused on this little baby in front of me and not focus on that person in the corner who's not paying attention to what's going on in the room, who's doing whatever in the corner, not attentive to this child that should be the focus, and is just kind of staring off, doing nothing, chatting.
yeah.
The
Like
whole thing is
la di
making my
da.
the whole thing is making my brain explode. Um, but the things that stick with me about Isabella is that she is dressed in this immaculate, and it's been cut now, but this immaculate blue and white frilly dress, and she has the overwhelming scent of baby magic. Do you know what baby magic is?
I do.
It's, yeah. So that scent is very
It's
specific.
very specific. Yeah, that's
Yeah.
a very specific reference. Yeah.
To this day, to this day, I think of Isabella every time I smell baby magic. That's
Wow.
how much that case impacted me. Part of it was because it was stressful, part of it because I was new, but it was a major changer for me. Now,
Yeah.
I get out of this room. Now, remember, I just started my shift. I got assigned, we were 3 to 1 at that hospital. So I had 2 other rooms, and I got assigned the code base because that's the room I took. So I had room 1, 2, and 3. So somebody else had been covering those other 2 rooms of mine in my pod while I was in room 3. Um, so I'm cleaning up this, getting the family out, getting the body ready for the coroner to come, and blah blah blah. And then our nursing supervisor comes and takes care of the death packet and all that stuff in the
Mm.
coroner. So thankfully I didn't have to do that. But I'm finishing up my charting, da 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 da. I come out of that room and I have 2 other rooms to deal with. So this is what's going on in my mind, right? So I have to take all of my grief, anger, everything that I just experienced in the last 3 hours. What do I do with that? I have to do something with all that so I can go take care of 2 other patients,
Right.
right?
And
And so,
act like nothing's wrong.
and act like they're my most important thing,
Absolutely.
right? And so this was the first time that I realized this juxtaposition between caring for patients and caring for yourself.
Yeah.
And I realized that there's uh, a knife's edge that we have to walk, right? You have to care for yourself though, because here's the risk. If I don't deal with Isabella, what I'm going to do is I'm going to put her in a box and I'm going to shut her on a shelf in my mind.
Yep.
And then once I've closed that box, I'm never going to be able to open it back up again. Or a better analogy might be, I'm going to wrap her up in something and I'm going to throw her into my backpack and I'm going to walk around for the rest of my days with that weighty stone in my backpack weighing me down forever. Because once I've not dealt with her and carry her around, now I'm constantly holding her in my back, on my back, right? And eventually, all the Isabellas and all of the other scars and injuries and vicarious trauma that we get, because let's be honest, Kevin, there's no way that you and I can see the shit that we see day in and day out and not get affected by it.
Like, do you ever sit there and think to yourself, like, am I psychotic or something? Because like I mean, there's thousands of patients that we've seen, thousands of lives that we've touched, and so many of them, like, I'll never even close to remember. Like, it didn't affect me even a little. But there's those few that still wake you up in the middle of the night.
Right.
There's those few that still make your heart hurt every time you hear that name or smell that baby magic. Mm-hmm. There's still those few that make me say, okay, right, maybe I'm not, a complete sociopath.
Yeah. And now I was lucky because as I walked out of that room, Sandy, my charge nurse, and somebody else, I don't remember who the other person was now, but I remember Sandy was there, and she stopped me and she gave me a big hug. Ooh, I'm going to cry. But this is how much I still carry Isabella with me. And she gave me a big hug and she said, you know what? You need to stay away from your other rooms. You need to go on a break.
Yeah,
right.
We got this. We'll take care of this for you.
She's like, we've been covering your other rooms. You're fine. Why don't you go get breakfast? Take whatever time you need. And if you're not ready when you get back, then we'll figure that out too.
Wow.
But you need to go.
Good for them.
And I was like, okay. And so I went and I took like a 30, 45 minute break or whatever I did. And I cried a lot. But that's what they did. They diffused me.
Yeah.
And it was the first time I realized that that's what we do for each other.
Absolutely.
Right?
Absolutely.
Because we can do a CISM, which is what we did with the 14-year-old, the boy, right?
Yeah.
We did a formal debriefing, and that was the first time that I really saw the power of a debriefing. I saw how it can be done, and I saw how amazing that was for me personally. I don't know how everyone else did with it. Like, I don't know because I'm not them, but I saw how it was great for me because I was the primary nurse for him. So I saw how much it helped me, right? But with Isabella, I don't think we did a debriefing. Honestly, I don't remember if we did.
Yeah.
But
you did your own debriefing.
But we did a diffusing. And Sandy and somebody was standing next to her. I can't. It's like a blur. I can't see who it was now in my head. But I remember Sandy giving me a big hug. And Sandy wasn't really a big hugger. But she did. And and made me step off the floor, forced me to step away.
Good for her.
Deal with it right then.
Good for her.
And and it was, and in real time, I might have resisted her or whatever, but she just didn't make it an option.
Yeah, it just wasn't an option. So here's what you're doing.
I need you to step away. Yeah, I need you to step away. And I was like, okay, I'll do it. And it was very helpful because like we could have, hugged it out right there and cried, but it's always case by case, whatever you need. But I tell people that all the time. You got to find something to deal with your own built up emotions. Now that could be whatever, maybe you run, maybe you knit, maybe and it could even be, I always tell people, hey, maybe it's even something not so healthy. I don't encourage that, but even something unhealthy is better than not doing anything because that will eat you up from the inside. Now, I'm not saying you should go drink or do drugs or drive too fast or do something. I'm not encouraging that. That's going to be damaging as well. But I know what will happen if you don't do anything. So, I encourage something. Talk to somebody, have a friend at work, someone that understands,
Absolutely.
Something.
Absolutely. It's critical. It's critical to your well-being to be able to defuse a little bit and be able to have people that you can talk to and care and that care about you.
Yeah,
It's what makes this job possible. It's what makes this hard job possible.
absolutely. Well, and then you and I think we do it through ENA,
Oh,
right?
absolutely.
Um, I've
Absolutely.
been going for 15 or so, 15, 16 years or whatever.
Uh,
And, some years I don't even like I register for it and I go, and sometimes I don't even always go to the sessions. I go because I want to go to the mingling. I want to go
right.
to see my friends, my family at ENA because I want that interaction. I want to see my Kevins and I want to see my Jeffs and I want to see my, you know, my Anne Marie's and I want to talk to you guys because sometimes I need that release. I need to be able to talk to somebody I know gets me.
One of the coolest things to me about going to a conference is just that you get to see the people you see maybe once or twice a year,
Yeah.
and you just love seeing those folks. You love seeing those folks and seeing them for the first time, first time in a year, and you catch up, and it seems like you were just together yesterday. It's like there's no
Yeah.
time lost. Yeah,
Yeah.
we keep up with each other on Facebook, but there's no substitute for being in the same room, sitting at the same table, breaking bread with the same people.
Right.
It's just different. There's no substitute for that. It's one of the things I love the most about emergency nursing is what a community it is. When my wife went through everything she did when she went through her transplant, um, everyone was so kind and everyone was checking on her and everything else. But the ENA folks, my ENA family from around the country, they were the ones calling me saying, "Hey, are you okay?"
Yeah.
Everyone's asked about her. How are you doing?
Yeah.
And I really appreciated that. And they were all the folks that reached out every day. They were like every day when my wife was in the hospital, I was getting calls and text messages from New Jersey, Virginia, all over the world, and Joop from the Netherlands sent my wife a card. It's like, how cool is that?
He is amazing.
He is amazing. He is amazing.
Yeah.
So it's
Yeah.
it's just
A lot of
cool
love in
to,
that group.
yeah, a lot of love in that group, which is really makes a big difference.
Yeah.
So
But that when you asked me the question before, what is it about our profession that what is it that about it that drives me or that I I really hold dear, and it's all of that. It's all of that. So even if I lost my license tomorrow, I'd still have all of that. I'd
yeah,
still have That's what makes me a nurse. It's really not the
absolutely.
RN. It's more of what makes me a nurse.
That's that's profound. I mean, that's like, you're right. You're absolutely right.
It's also why we never stop being a nurse,
Right?
right? My mom, she retired in 2003.
Was she a nurse?
She is a nurse.
She
Yeah,
is a nurse. That's sorry.
she's an ER
Yeah,
nurse as well.
you can't say was a nurse. You got to
I
say
mean, she
is a
she
nurse.
she
It's
she
true.
did practice as a nurse, and
Yeah.
now she's a nurse. Yeah,
Yeah. Yeah.
yeah. She was an ER nurse, and actually, that's how we met Jeff. Jeff was her ER director in
No
Rolla.
kidding. No
Yeah,
kidding.
and then he went from her hospital to my hospital and hired me in the ER in Salem.
Wow. Small
Yeah.
world.
Yeah, isn't that funny? And that's how Jeff and I became friends because in my interview, it came up that he had been my mom's ER director just prior to my ER manager.
How funny is that?
Yeah, so he kind of took me under his wing, and that's how we became close, and we became very good friends since 2001 or whatever that was.
That's really awesome.
Yeah, it's kind of a
It's
small weird world, but
it
yeah,
is a small weird world, isn't it?
yeah. But
What's the best advice your mom gave you about being a nurse?
um, take care of yourself. That was one of the things, and stand up for yourself. She came out of the era where nurses had a smaller voice, um, and she was never good at that. She was never
Yeah.
good at standing,
Love
getting up
those
her
nurses.
chair.
Love
Yeah,
those nurses.
she said I did it because I had to, but it always graded. So she said, you know what, you be you, and don't apologize for being smart. Don't apologize for asking questions. Um, she said, do it with dignity and do it with respect, but never apologize. Um, but she also said, remember who you are at the end of the day, um, and remember who you have to be when your day is over. um,
I like
and make
that.
sure that your actions allow you to still be that person when you go home.
I like that. That's good advice.
Yeah.
That's good advice. The last question I always ask everybody is I ask everybody a question called 3 things. I'm going to ask you, Bill, what are 3 things an ER nurse should always remember, and what are 3 things they should just go ahead and forget?
3 things an ER nurse should always remember. I think we should always remember that we are a part of the patient's care. We are not the only care they receive. Remember that there's someone before and after us. Um, so our care matters, but it's not the only care they receive. That's
Part of the bigger team.
Yeah. Remember that the questions that we have um, for others outside of the emergency department, um, focus those questions with that in mind too. When you ask questions of your pre-hospital counterparts, remember they do a different job than you do, right? Don't ask them to do your job.
Right?
Ask
Yeah.
them what their job was.
Yeah. Yeah.
Don't ask them why they didn't do your job. Ask them what they did, right?
Yeah.
Ask them what they experienced. And when you get questions from your inpatient um, care providers, your nurses upstairs, if it's upstairs to you, um, remember they're doing a different job. So when they ask you about how the patient walks or how their butt looks, right? Remember that's important to them, right? Don't roll your eyes. Don't be snotty, right? Remember, answer the question if you know it, and give them the information you have, right?
Yeah.
We're all part of a care continuum. We're all trying to help the patient. And the third thing, keep learning, right? Never sit on your laurels. Um, Healthcare and medicine and nursing always evolve. Continue to learn, continue to grow, and continue to re-examine what you know. I've been doing this a few minutes, right? And I still am astounded by things I thought I knew and I had it wrong, right?
Yeah.
My understanding changes as technology changes or as I just realized I didn't have it right. So always question, always challenge yourself, always question, listen to new ideas, um, ask questions, re examine, be open to new ideas, always continue to learn.
Absolutely.
Things you can go ahead and just
Forget.
forget. Um, how about we all just drop from our vocabulary? That's how we've always done it. I think that's a great thing to
Love
just
that.
get rid of. We don't give a shit how it used to go. Okay. Be
I love
innovative,
that.
be vehicles for change. Um, we don't need to innovate just for innovation's sake, but um, it goes right along with provocative learning, right? As we learn, we should learn for the right reasons, but if things can be improved, let's improve them. Um, yeah.
That's
Um,
that's going to be a quote. We don't give a shit how things used to be done. I'm going to quote you on Facebook today. I love that.
uh, I'm gonna get in
So
trouble for that now.
one of the things I do on the website is on my webpage on the podcast webpage, I always put a picture of the person and then put like a little quote, and that's going to be your quote.
All right. Another thing we can just forget. What's another thing we can just forget? I don't know. I think, well, you know what? I'm not sure I can boil this down into a catchphrase, but the idea that we're here to provide care for a patient and we need to foster the relationship. We're not here to judge the patient. So our personal views have no place in patient care. So this goes to all of those things. So we leave our judgments at the door. We laugh a lot, especially in like my seminars, right? I laugh a lot about judging, right? I
Yeah.
make a lot of jokes about how we judge patients and stuff, and we do, right? And I make it in a funny way. But really, judgments should be left at the door, right? We're there to discern, to diagnose, to do things like that, right? To differentiate. But really, judging, they they have no place in medicine and nursing, right? Patient comes in, no matter who they are. Doesn't matter if they're a frequent utilizer of services. You can call that whatever you want it to be, but
Yep.
doesn't matter if they're from a different socioeconomic group, a different racial group, a different faith group, a different gender group, right? It doesn't matter. They're a patient and you're a nurse, and that's your only relationship that matters, right?
Yeah.
So forget the rest of it. Your personal beliefs, your spiritual, your political views, none of that matters. You're a nurse and you're there to care for your patient. So that's really the relationship you want to foster.
Yeah.
Um, so forgetting the rest of that.
I
A
like it.
third, I'm not sure I have a third one. Forget the small stuff. We have enough on our plate. We have enough stress in our life. Let's not borrow trouble, right? Um, Sometimes we gotta when we clock out of our shift, we sometimes have to leave the stresses behind too.
It's sometimes hard to do.
It is, but we have to have boundaries. We have to, when you clock out, leave your badge somewhere that's not with you. Like if you have to take it with you, leave it in your car. Don't take it in your house, right? Have
Yeah.
something that separates you so you don't take it with you. If you don't have to bring your scrubs in, if you can do something physically to separate, like your shoes, if you can leave those somewhere else, don't bring them in your
It's
house.
good advice
Some,
anyway.
I know, right? Don't bring the MRSA in, right? But just some physical representation of a separation of your personal and your work. Um, I'm not sure if that's a forget, but your boundary setting. You gotta have time off, right? You got to be able to separate. You have to have downtime, and that kind of comes back to maybe Isabella, right? You got to do some self-care.
Yeah.
You gotta vent that negative emotion. You got to do something for you.
Self-care is important, and you're right, and forgetting, like, and actually taking the time to decompress. Like
Yeah,
I don't know how many years I've gone through and didn't take vacations. Like
yeah,
I never took a vacation. Because
yeah.
every vacation I'd spent, either going and teaching and working,
Did that
or
for
go take vacation and go to maybe a conference or something, which is still nursing.
yeah,
And very little time did I take off and say, I'm just gonna go and not be a nurse and just go be a husband and have fun and
yeah,
all that stuff. So I think that's it's now I look back and go, what was I thinking?
yeah. And Jeff and I talk a lot about in our current roles. We work too much, right? We were just talking yesterday about we need to actually plan some downtime.
It's easy.
We have to schedule it.
It's easy when you love what you do. It's easy to work
Yeah,
a lot,
yeah,
but it's still not healthy.
yeah. We both were saying that especially this fall, we have scheduled too much, right? We put in every minute of every day. We've scheduled things that they're all work, right? So
Yeah,
yeah, you got to do some things just for you. So I'm
absolutely.
not sure that's a forget, but if you can wrap that into a catchy forget, that would work.
Yeah, no, I think that's just good life advice, right?
Yeah.
All right, Bill, that was awesome.
Well, I enjoyed it. Thanks for inviting me.
This is a lot of fun, and oh my god, the lessons are just incredible. You could tell you're an educator. You're an educator through and through. It's like, yeah, you can tell the story, but you're like, let me tell you the lesson behind the story, and
Well, I can't
I
shut up. I'm
love
super
that.
nerdy. I'm
I
super
love
nerdy.
that.
So I feel like if there's not a takeaway, I failed. So
Well, there's plenty of takeaways in this episode. So that's fantastic. That was really, really good.
Well, Kevin, I really appreciate the opportunity.
This has been a lot of fun. So thanks again, Bill, for spending time with me, and I really appreciate it.
All right. Thank you.
Take care. Bye-bye.
Bye-bye.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.